Okay, so basically I'm going to go over an overview of chorea and tics. We'll start with chorea. As you may have heard in other sessions this week, chorea is defined as involuntary, brief, random movements that flow randomly from one part of the body to another. It's usually chorea is considered to be in continuum with ballism and athetosis. When you have much more severe movements, it tends to be more considered to be ballistic, and then slower, more writhing movements are considered to be athetosis. There are some physical signs of chorea. You've probably seen in some of the videos this week. Milkmaid's grip. When you ask someone with chorea to squeeze your fingers, you're going to feel kind of an impersistence in this grip. So it's considered like milkmaid's grip. Also, flycatcher's tongue. They have an inability to keep the tongue protruded, and the tongue will kind of go back into the mouth. Other terms, parakinesia is when there's a camouflaging movement to hide the chorea. So in other words, if someone has chorea of the arm, they'll kind of fix their hair or such to kind of make it look like they're not having a choreiform movement. Patients can partially suppress these movements voluntarily for a brief period of time. Now, this is where I have some slides here. Okay. Do you have it in here? Oh, thank you. Okay, so this patient has familial chorea, and you'll notice her hand movements. She can't really quite keep them still. Her fingers are moving and such. And that's her chorea. She also has some movements of the feet as well. Okay, and then this woman has a much more severe form of chorea. She has chorea gravidarum. And you'll notice she can't keep her left arm still. She's holding it with her right arm. She's really trying to suppress these movements. She sits on her feet, and you can see her feet moving around as well. Okay, and then the last one, let's move this here. This woman has genetically confirmed Huntington's disease. She's had the disease for several years, but you can notice her legs are just not holding still at all, her arms, her shoulders. So it's kind of this continuous flowing movement. Okay. So when you look at the classification of chorea, you start with either hereditary or sporadic forms of chorea. And hereditary forms, you would be considering Huntington's disease, which is the most prevalent or the most well-known, Huntington's disease like 1, 2, and 3, spinocerebellar atrophies, dentatorubropalatal Lewisian atrophy, Wilson's disease, neuroacanthocytosis, neurodegeneration with brain iron accumulation, and benign hereditary chorea. Sporadic forms include Sydenham's chorea, tardive dyskinesia, SLE, antiphospholipid antibody syndrome, chorea gravidarum, etc. So you can read these in the list here. Now, a little bit more about Huntington's disease. I know you've probably heard about this quite a bit through this meeting, but Huntington's disease is an autosomal dominantly inherited neurodegenerative disease with age-dependent penetrance. It's the mutation is on chromosome 4p16.3. It consists of CAG trinucleotide repeats and has anticipation. And what that means is that with each successive generation, the onset of the CAG repeat number expands or gets larger, and the onset of the disease is earlier. In Huntington's disease, chorea is one of the most well-known symptoms, but also there's dementia and psychiatric symptoms as well, and depression and suicide are very common. Genetic testing for Huntington's disease is available. Now, determining whether a person has Huntington's, the number of repeats will tell whether they definitely have the disease or not. Now, from 10 to 35 repeats, that's considered to be normal, and they will not develop the disease. There's an indeterminate from 36 to 39 repeats where they may or may not, and then greater than 40, they definitely have Huntington's disease. The onset of the disease is usually between 30 and 54 years of age, but it can be as young as 4 years and as old as 80 years of age. There is a Westphal variant when the patient develops signs of Huntington's at a much younger age, and when this occurs when they're younger than 20 years of age, there's less chorea than there is when it's an older age of onset. In fact, Parkinsonism and dystonia tend to be more common in these patients, and it's thought that this variant is a more severe disease state. Treatment of Huntington's disease currently is palliative. I know there's a lot of investigations and new medications that are being developed, but at this time, we pretty much treat the chorea when it's disabling, symptoms such as the psychosis and depression when it's needed. And for treatment of the chorea, we use tetrabenazine, deutetrabenazine, and neuroleptics. Remember that you can develop another form of chorea, tardive dyskinesia, with use of neuroleptics in this population as well. Additional medications that have been used include riluzole and amantadine. Now, in terms of the sporadic forms, the most common form or the most common cause of chorea is drug-induced. And I say that because there's many different drugs that can cause chorea. In fact, one of the most common ones that you're probably well aware of is levodopa. 40% of Parkinson patients will have levodopa-induced dyskinesias or chorea. Neuroleptics, they will cause tardive dyskinesia, orobucolingual masticatory type movements, oral contraceptives, tricyclic antidepressants, as well as SSRIs, calcium channel blockers, and some of the anti-epileptic medications as well. And of course, drugs of abuse, such as amphetamine and cocaine, can also cause chorea. Briefly about autoimmune chorea. Sydenham's chorea. It's the most common form of childhood chorea. It's a major feature of rheumatic fever. It's caused by group A beta hemolytic strep infections. They have found anti-basal ganglionic antibodies in this disorder. Generally speaking, Sydenham's chorea has a self-limited course, so it will resolve over time. But in up to 50%, they will have persistent course. And I did have a patient who was in his 60s who still had chorea, which he had obtained when he was a child of Sydenham's. Treatment of the chorea is only when it is disabling, because most of the time the chorea will resolve on its own. SLE, Parkinsonism, and myoclonus are much more common than chorea in this disorder. Chorea is also associated with antiphospholipid antibody syndrome, and just as we saw in that woman, chorea gravidarum, it's a hormonally mediated form of chorea. Anti-basal ganglionic anti-basal ganglia antibodies are also involved in this case. And most of the time, this is self-limited. In this patient that you saw earlier, however, she has persistent chorea. And she actually had 3 children, and each time she was pregnant, she had the chorea. And then after the last one, the chorea never resolved. Now, this is more important. What are you going to do when you see a patient with chorea? You need to figure out what was causing it and whether or not you can treat that. If it is suspected hereditary chorea, then you want to do genetic testing, and we have testing for Huntington's, spinocerebellar atrophies, and DERPLA. Also, you want to get a blood smear looking for neuroacanthocytosis, CPK, serum copper and ceruloplasmin, looking for Wilson's, and EEG and MRI are also helpful for diagnosis. If it's considered to be sporadic, no family history of chorea, you also want to get a CBC complete metabolic panel, ASO titer looking for evidence of Sydenham's, antiphospholipid antibodies to look for the antiphospholipid syndrome, thyroid panel, perineoplastic panel, HIV, and MRI is also helpful. Now, treatment of chorea in general, tetrabenazine and deutetrabenazine is helpful. So just as what I mentioned for Huntington's, this goes for treatment of chorea in general. Atypical neuroleptics are considered to be also very helpful for chorea in general. But again, you have to look out for the side effects from these medications. Additionally, valproic acid, benzodiazepines, and riluzole have been used to treat chorea. The mainstay is, though, you have to treat the patient. If the patient has chorea, like in the first case, that woman has a little bit of chorea in her fingers, she really doesn't need much in the way of treatment. It's not interfering with activities of daily living. It's not disabling. So you need to treat the patient, and when they need treatment for the chorea, then you use these medications. Okay, we'll move on to tics. Tics are semi-voluntary movements that are sudden, brief, repetitive, and stereotyped. They occur without loss of consciousness, which differentiates them from seizures. They mimic normal movement fragments. Tics can be motor or vocal, and they often call it phonic because not all the time are the sounds words. Tics can look like any other kind of movement, such as myoclonus, dystonia, or chorea. Differentiation in tics, there usually is a premonitory sensation or urge, which is relieved with performance of the tic. Now, tics are classified in either simple or complex forms. Simple motor tics, few muscles are involved. Clonic tics are brief and sudden. Dystonic tics have longer contractions. Tonic are isometric, and these examples of these are like blinking, nose twitching, head jerking, and shoulder shrugging. Complex motor tics involve multiple muscles. They are more coordinated and sequenced type of movements. There's also sometimes echopraxia, when you have imitation of gestures, coprapraxia, where you have obscene gestures. And examples are jumping, kicking, and squatting. And now, let's see here. Where did you put it? Sorry. Oh, okay. So, simple tics. Okay, this is an example of a woman who has simple tics, and she actually has, her 2 daughters have Tourette syndrome, and you'll notice that she kind of jerks. She has this, she does have the premonitory sensation. Right now, this is a normal neurologic exam, but you'll notice that she'll kind of intermittently have these abdominal contractions. There you go, just like that. Okay, and then here's an example of complex tics. And this patient is actually trying to suppress them. He doesn't really want them to occur. He actually has some phonic tics along with this. And the last one is also a complex tic. So you'll notice he has some facial expression, some eye rolling, and of course the neck movement, which is pretty prominent. And during this video, I know the sound isn't there, but he kind of tells you what he's feeling when he has these tics. So before these tics, he says he's not calm. He needs to feel relaxed. So in order to feel relaxed, he has to perform the tics. Okay. So now, vocal tics or phonic tics are also simple or complex, and simple phonic tics are sounds that don't form words. These include sniffing sounds, throat clearing, grunting, squeaking, coughing, and blowing. Complex phonic tics are when there's words or fragments of sentences. Palallalia is when there's repetition of one's own last syllables, word, or phrase and sentence. Echolalia is when you repeat someone else's words or phrases. Coprolalia is when there's obscenities or profanities, and that is probably the most well-known thing that is associated with Tourette's syndrome, but in fact is not the most common symptom of Tourette's. Additionally, suppression of tics is possible for a short period of time. Most of the time when a person suppresses the tics for a period, they'll have a rebound or a flurry of tics afterwards. The tics tend to occur more frequently with stress or fatigue, and also when they're at home, when they feel like they're in a comfortable environment. Tics tend to wax and wane, varying in frequency and severity. They do not usually disrupt voluntary movement. Now, the onset of tics is commonly in childhood, usually under 18 years of age. They tend to improve over time, and by 18 years of age, about 50% of them are tic-free. Now, tics in adults, because most of us see adults, adult onset is rare and usually represent the reoccurrence of tics from childhood. In a study of 57 patients by Dr. Getz with Tourette's syndrome, they found that the tics persisted in all patients, but were only moderate to severe in only 24%. So the majority of them, the tics lessened in severity over time. In adults, face, neck, and trunk tics predominate. Now, differential diagnosis of tics is pretty large, including myoclonus, chorea, dystonia, all of these because of the type of movement that the patient is performing. Also, akathisia, which is a side effect of neuroleptics, is considered to be possible as a differential. Mannerisms are fidgeting. Most everybody has a little bit of fidgeting. This might be a little on the excessive side, and they probably do not have that premonitory urge that you have with tics. Stereotypy, restless leg syndrome, and seizures are also considered in the differential. Now, causes of tics are many. For primary types of tic disorders, there's a transient motor or phonic tics that occur for less than 1 year. This generally occurs in childhood, such as the chronic motor or phonic tics that occur greater than 1 year, and these also occur usually in childhood. Tourette's syndrome is probably the most well-known and most common form of primary tics, with adult onset of recurrent tics occurring as well. Hereditary, also Tourette syndrome has some hereditary component. Some tics are found in Huntington's disease, neuroacanthocytosis, neurodegeneration with brain iron accumulation, and Wilson's disease. Secondary forms of tics, infectious disorders such as Creutzfeldt-Jakob disease and encephalitis, Some drugs will induce tics, such as amphetamines. Levodopa has been reported to induce tics, carbamazepine, and of course dopamine receptor blocking antagonists. Toxins, including carbon monoxide. In developmental disorders, tics are found in autistic spectrum. Also, some people with head trauma, strokes, and schizophrenia also can have tics. Now, diagnosis of tics is clinical. There are no lab or imaging studies. You need to make sure that their medications are not something that could cause this. Looking for secondary causes if they have a suggestive neurologic exam and history. Additionally, in Tourette syndrome, especially in childhood, obsessive compulsive disorder and attention deficit hyperactivity disorder commonly helps with that diagnosis as well. Now, treatment of tics, the goal is to reduce the tics to a tolerable level, not to eliminate them completely. Education, as has been mentioned in the talk on Tourette's earlier, is very important, educating the patient and the patient's family, etc., so they understand what's going on. For mild tics, behavioral treatment seems to be sufficient, and there's been several forms of behavioral treatment, including mass negative practice, operant techniques, anxiety management, and exposure-based treatment, as well as awareness training. However, the most effective appears to be habit reversal training, and this has been found to be as effective as medication in reducing tics when it has been tested in children. Habit reversal training includes increasing the awareness of the tics, recognizing and resisting tic urges, and they give them a positive way to manage the disorder. Now, if behavioral treatment is not sufficient, medical treatment is then initiated. Dopamine receptor blocking antagonists are a mainstay of treatment, such as fluphenazine and haloperidol. Atypical antipsychotics, risperidone, olanzapine, and quetiapine. Tetrabenazine has been used to treat tics with some success. Alpha-2 antagonists such as clonidine and guanfacine are commonly used, and sometimes benzodiazepines such as clonazepam are helpful. Now, there have been some alternative agents or treatment of tics, including dopamine agonists, which seems to be effective in some cases, topiramate, baclofen, and botulinum toxin injections. Now, botulinum toxin injections are useful when the tic is focal, and these injections will help to reduce that movement. It also helps to improve the premonitory sensory component of the tic. Now, also, DBS has been used in treating Tourette syndrome and severe recalcitrant tics. Unfortunately, at this point, there's no optimal target that has been determined. So in conclusion, chorea and tics are two different hyperkinetic movement disorders. Treatment tends to be like for most hyperkinetic movements, dopamine receptor blocking antagonists, and research in pathophysiology and further treatment are required. Thank you.